Now, why robotics? So, robotics is we have quantified gap balance. Before surgery, we are now able to identify what are the gaps we will be achieving. We have the real-time ligament assessment, data-driven decisions, and we can adjust plans in real time, and we have a personalized TKA. So, if we want to have a different, any other different philosophy than mechanical alignment, then we need to have robots. Why imageless TKR? It is faster, it is easier, and it is equally precise. What you need is to be easier. So different systems are imageless are ROSA, Navio, Cori, and other are image-based system. ROSA is a hybrid system where you can even use the X-ray based or X-ray imaging to have the pre-op plan. It has 2 units. In an image-based, you have to have a specialized X-ray with a marker tied on the legs, and that has to be uploaded in the portal, and you get the image plan. Now the operational process for imageless TKR is tracker installation, hip center marking, surface mapping, soft tissue assessment, planning screen adjustment, and bone cutting. So tracker placements are, we have to put 3.2 mm pins in femur and tibia, which are usually now I put is unicortical. Surface mapping starts with femoral head center marking, femoral canal entry point, anterior and posterior trochlear groove, which will mark out the apex of the femur. Then the medial epicondyle, medial distal condyle, lateral condyle, and lateral distal condyle. Now, as Dr. Rutul pointed out, you need to be precise in marking, and it is always a learning curve where you have to be very precise. So if you put in a wrong data, you will have a wrong data out, and that is true for image-based system also. If your RMS is not matching, then also you will have a problem. So you have to do mapping of the femur, you have to do mapping of the tibia. There are total 17 registration points. It takes around 3 to 4 minutes to complete the whole registration process. And you have the bony landmarking done. Then comes the soft tissue assessment, where varus and valgus thrust is applied on the leg in different degrees of flexion, where you have the data of the ligament tightness, soft tissue laxity on medial and lateral side in 0 and 90 degree of flexion and extension. So after this bony and soft tissue assessment, you have an initial soft tissue assessment screen, and with this data, robot will generate a pre-planned screen where with the standard cuts of 10 mm on lateral side, what would be the gaps in flexion and extension. So if you go by a mechanical alignment, we can proceed with this plan, just we can adjust the gaps on lateral side, and this is the workflow. Like if you want to go for the mechanical plan, you can go ahead with this. And with this, we can start with a workflow of femur cut or tibia cut, whatever you are selecting. So in the robot, I usually complete the femur first. I take my distal femur cut first. The robotic arm comes into the cutting plane. The zig is fixed on the bone, and the cut is taken through the zig. So the tactile feel of cutting would not be lost. So here the cuts are taken, which are then again validated. You are precise, that can be validated. Then comes the 4-in-1 cutting block. 4-in-1 cutting block, the cutting the 4-in cutting pins are placed, and over that the cutting block is placed, and all the cuts are taken. Then the tibial cut is taken through the robotic zig. The zig is pinned to the bone, and the cut is taken through this zig. So when I shifted to robot, I have started doing all femur first, as I know my balance gaps I have checked. So I complete my femur first, and then I do my tibia, so that my tibia forwarding is very easy. Then the cuts are validated for tibia, and the soft tissue assessment is done after putting on the trial implants. So here I can have the degree of deformity which is corrected, and the laxity which is now present on medial and lateral side, and the instability, if it is there only in any mid flexion, it can be identified. Okay, so this is the final assessment screen. So now if we come to the different philosophies, that is kinematic plan. So I'll run through one plan. So this is the initial assessment screen, where with 10 mm cuts you are having gaps of 23 mm in extension, and flexion it is 17. So in a kinematic plan, you have to have a 2 mm cut difference between medial and lateral side, and in flexion, you have to have an equal cut on both posterior condyle. So by keeping a femur valgus of 3 degree, the cut on lateral side was now 7 and medial side is 5, and in tibia it is 8.5 and 6. So now we have a equal cuts on both medial and lateral side in extension, and in flexion equal 8.5, 8.5. So we are now practically resurfacing the bone. So in a kinematic plan, what we can achieve is we are resurfacing the bone and we are having minimal soft tissue release. So in a kinematic plan, what would we see? Like we will be seeing the X-rays which will be showing virus in tibia, but patient satisfaction index would be very high because there would be no soft tissue handling. There are enough studies to compare efficacy of different studies. So across all major studies, accuracy is equivalent, outcomes are equivalent, superiority is not proven for image-based. Imageless wins on efficacy, simplicity and practicality. What you want is not, you don't want to mess up your OT OR setup. So image-free setups, image-free options, advantage is no CT scan is required, optimized landmarking setup registration without surgeon can be done. It is same as conventional surgery, so learning curve is very less. So in case anytime you need to abort the system, which is not happened in any imageless case because the workflow is same, but it is very easy to convert into a conventional case. So limitation, as Dr. Rutul have highlighted, there is no preoperative plan, and if there are registration errors, you can have some problems, but it is a learning curve. You can easily identify that you are wrong or right after taking registration. Thank you all.